on the third Thursday of most months throughout the year on a different topic and how it intersects with homelessness. Tonight, we're going to talk about health, housing, and homelessness, and that is what we're covering today with our expert panelists. Thank you all for joining so much. We know it's a choice to come and spend your night with us, so we really appreciate you taking the time to spend this hour, a little over, talk about this important topic. As always, I want to start with housekeeping, a little information. I know we've been doing our Zooms for a few years now, but always good to have information on the format of this specific event. So we do have live captioning available if you need that. Just go to the bottom of your screen, hit the CC button, and you should be able to see auto-generated captions for everyone speaking. Our agenda for tonight is like most of our nights. We're going to start with a little data presentation about the topic. Then we're going to introduce our panelists and have some questions for our panelists that we've planned. And then at the end, we'll get to the Q&A. So if you are here as a guest, please use the Q&A function to put in any questions you're going to have for our panelists that you think of now or you think of as we're going. We usually don't stop to answer them in the middle. We answer them all at the end. So put them in, and we do always dedicate time at the end to make sure that we get to them. Please use the chat to connect. So everyone who's watching is camera off. So maybe you can be cooking dinner or doing whatever, so your camera off, but you can still always use the chat, introduce yourself, make connections. We know we have a lot of people who work in the sector who attend, so please feel free to chat amongst yourselves, have conversations, and often we get great information in the chat from people who sometimes work in the sector and have the answers to the questions that are being asked generally. Just want to inform everyone the session is being recorded. That is so we can make it accessible on YouTube. We usually have it up on YouTube the next day. So hopefully tomorrow, Friday, this will be on YouTube and ready to share. If you find it interesting, you can share it out with folks. I'll also mention that the presentation we always make available in our follow-up email that'll come to the address you registered with. So if you find the information compelling and you want to take notes, don't worry, you don't have to take notes. We'll send you the slideshow after the fact and you can just be present. And if you want to share on social media, our wonderful digital communications manager, Shannon Webster, will be sharing from the Colorado Coalition account at CO Coalition. If you want to share anything, if you're learning, feel free to tag us or use hashtag CCH Ed Series. And then I've also put the handles for some of the other organizations who are with us today, Denver Health Med and UC Health at their handles. So in our data overview, as I said, we're going to try to keep it pretty big picture. The idea is that we're providing data on health and homelessness so that anyone who's coming in and sort of 101 doesn't know about the topic is going to get a pretty good idea of the landscape before we talk to our experts working in the field. So we're going to cover general health and homelessness, health as a cause of homelessness, how homelessness hurts health, access to care, primary and emergency care, and then what solutions work. And that's a lot of what we want to talk about when we get to our panel is what actually works to solve the problems. So health and homelessness are really intertwined. Some health problems precede and causally contribute to homelessness. People who have health conditions that prohibit them from working, that cause them to not be able to keep up in various ways, they can affect your ability to pay your bills, to keep your housing. So we know that health issues can cause homelessness. We also know that once someone is experiencing homelessness, their health outcomes become worse because of the way that folks are living. It is much harder to live unhoused. And that homelessness can complicate the treatment of many illnesses. So while you may have been able to keep up with an illness, you're going to have more trouble when you're experiencing homelessness. So health is a cause of homelessness. Health, including mental health conditions, can make it harder to perform day-to-day activities and maintain your housing. Unforeseen health events or injuries and associated medical costs can come as a financial shock that pushes people towards homelessness. So just the medical expenses alone, even if you have had that issue resolved, the medical debt will live on beyond the period in which you were being treated. It's especially difficult to cover costs if you don't have access to quality health care, which we know folks who are experiencing homelessness or at risk of homelessness or don't have high incomes, often they're not able to get quality health care. 71% of people experiencing homelessness have a mental health illness or a post-traumatic stress disorder. And when we talk about the impact of trauma, we also like to bring up ACE scores. So an ACE score is an adverse childhood experience. And essentially what it is incidents that happen to you in childhood that affect you later in life due to trauma. It's a traumatic experiences have a profound effect on us for the rest of our lives. And so what we find is that around 54% of people experiencing homelessness report that they've had 4 or more ACEs, and that number is only 3 to 5% of the general public. So there's a strong correlation between trauma, childhood trauma in particular, and homelessness. As I said, they're intertwined issues. This is a little bit more on that. 1 in 4 people with medical debt report experiencing housing-related problems such as eviction. So once again, just the sheer cost of medical debt is going to affect your ability to have stable housing. Any amount of medical debt increases the amount of time a person experiences homelessness by an average of 2 years. And health conditions are much more difficult to manage without stable housing, but can also make it harder to secure housing. Ways that homelessness hurts health. So very directly, people who experience chronic homelessness have a 15 to 30 year reduced life expectancy compared to their housed counterparts. Part of that is due to the conditions of experiencing homelessness, just day to day. So if you're experiencing homelessness, you're going to have an increased likelihood of experiencing violence. You're going to have a higher risk of traumatic injuries and assault. You're going to have exposure to extreme heat and cold, which is very bad. Both the extreme heat and cold we experience here in Colorado, and it has a profound effect on the clients that we work with. And lack of sleep, access to care, and resources to manage conditions are just going to affect you as well. Clinicians who work at the coalition, some of whom are on today, report that patients often have conditions similar to someone 15 to 20 years older than them. So I've had one of my colleagues say to me, if I'm seeing someone who's a 50-year-old patient, I'm going to look for conditions and treat them proactively in a way that's more for a 65 to 70-year-old patient because of the prevalence of this for someone who's experiencing chronic homelessness. Some of our most common conditions are that we see in folks that are seeking treatment at Stout Street Health Center or one of the other locations where we have healthcare here at the coalition. Most common conditions are hypertension, cardiovascular disease, low back pain, diabetes, depression and other mood disorders, substance use disorders, anxiety disorders, including post-traumatic stress disorder, respiratory infections, and then wounds or foot care needs. So some of the conditions people are experiencing are very different than housed people because of what it is to experience homelessness, whether sheltered or unsheltered. Limited access to care. So folks do not have as much access to care generally. We work to counter that at the Stout Street Health Center, and many other organizations are doing so as well. But some of the reasons that people aren't getting care, maybe if they haven't yet fallen into homelessness or if they're experiencing homelessness, some of the reasons that people cite are lack of funds or health insurance to make their payments. There's stigma that reduces engagement, that there's competing priorities, that if you are trying to figure out what you're eating, that is going to be your priority before like my toe hurts, right? And so people are making decisions of what their body needs most in that moment, and that may not be preventative care, and that may not even be care for something that's acute at that moment. And difficulty securing and attending appointments. So appointments can be hard to come by. If your tent has been swept and your phone is gone, it's going to be even harder to call for that appointment. There's a lot of reasons why people experiencing homelessness simply have trouble with the complex systems that often are part of healthcare. Those experiencing chronic homelessness are less likely to access ongoing regular primary care than those who have experienced homelessness for shorter periods of time. So once again, the longer someone experiences homelessness, we're going to see the impact of that in their body, and we're going to see the impact of that in their access to care. In terms of primary care, a study found that 59% of adults experiencing homelessness do not have a family doctor, and that's compared with 9% of the general population, the housed population. The odds of having a doctor decrease with each additional year of homelessness. 83% of people experiencing homelessness had not had a dental cleaning in the previous 4 years, and this rate is 4.6 times higher than in the general population. So once again, the same things showing up again about the impacts of experiencing homelessness and the longer you experience homelessness. In terms of emergency healthcare, our clients, people experiencing homelessness, are much more likely to seek emergency treatment for a few reasons. One, you're gonna get your treatment there, right? So if you weren't able to get an appointment, or you didn't have money for an appointment, you will have to be treated in an emergency room. So they end up oftentimes in the emergency room. But also their conditions become emergencies because they weren't able to be treated early on. People who are unhoused visit the emergency room 5 times a year, which is 4 times higher than housed counterparts. Excuse me. And in 2012, Denver city officials estimated that 250 people in the homeless incarceration cycle required $7.3 million in public services over a single year, cycling through jails, hospital emergency rooms, temporary shelters, and detox centers. So the fact that we're not helping people before it becomes an emergency is terrible for those individuals. It's also costly to folks. So what we're seeing is that at the end of the day, people have a lot of unmet needs. One study found that in the past year, 3/4 of people experiencing homelessness had at least one, or I'm sorry, they had one unmet healthcare need, but half had 2 or more. And the rates of unmet needs were 6 to 10 times higher for people experiencing homelessness than the general population. So now we get to talk about what works, right? Because we can see that this isn't working. What isn't working is people not being able to get preventative care. What isn't working is folks experiencing homelessness getting emergency services only. So what works? Preventative care. It's the first thing we have. You can get preventative care at a federally qualified health center. The Stout Street Health Center happens to be one of those, which the coalition runs, provides medical, dental, behavioral health, optometry, pharmacy, medical assisted treatment, case management, Medicaid enrollment, and assistance all in one place. We use trauma-informed care and motivational interviewing to serve our clients. So preventative care, one of the main things that works to counter this. Secondly, recuperative care. We have our director of recuperative care here tonight talking about how to fill that gap between hospitalization and essentially that moment when someone is well enough to go home from the hospital, but doesn't have a home to go to. That person is very likely to be re-hospitalized because they are not able to care for their wound or whatever their aftercare treatment is well unhoused. So what our new recuperative care center does is fill that gap. And so that's the John Parvensky Stout Street Recuperative Care Center. And it's basically for those folks. Most folks are there 30 to 45 days, but I know that this slide was made and our numbers were made before we'd actually open. We've just been open about 6 months. So I'm sure Miriah will have great updates on how it's been going now that we've opened our doors. And this is some of our care providers here in the picture. And finally, housing. Housing first, but not housing only. So residents that get housing first, essentially the idea is we're going to offer you housing, and then once you have housing, other things will come together. Once someone can stop worrying about where they're going to sleep, if they're going to be warm enough, the other parts of what needs to be done, their unmet needs, can be met, including healthcare generally works. So residents at our facilities that are permanent supportive housing, they're offered wraparound services, including on-site case management, counseling, substance use treatment, psychiatric care, medical care, et cetera. We have independent studies that this is effective for our SIB program, Social Impact Bond program, and our new Home to Health or SIPRA program. I will not go into the details because I know Jenny is going to do a much better job of going into the details than I will. But we know that housing first is a solution that works, and it's not just us saying that, it is data proven to be effective by external evaluators. So we have our panelists for the day. I'm going to start with Jenny Deering. I hope you all appreciate her photo. She did not submit a photo, and so we had to determine the right one and went with a deer, an obvious and beautiful solution. So Jenny Deering has been at the Colorado Coalition for the Homeless in various roles for the past 11 years. She currently serves as the Director of Housing First and Assertive Community Treatment, or ACT services. The Housing First and Assertive Community Treatment Services Department's primary goal is to assist people in attaining independent and permanent housing paired with wraparound services without barriers. Welcome, Jenny. Next, we have AK Kopperud. I apologize on the name if I pronounced it wrong. AK serves as project manager for the housing transitions team at the University of Colorado Hospital, where he manages ongoing projects related to UC Health's housing transitions team, including data collection and reporting, community partnership development, and providing ongoing clinical support. Welcome, AK. Myra Nagy, I apologize again, I did not double check names, serves as the consumer advisory board of the Colorado Coalition for the Homeless. The primary role of CAB members is to serve as a connection between CCH and clients. The CAB reviews policies, programs, and other decisions that impact consumers and the organization to better serve the needs of people experiencing homelessness. Myra is an artist and an advocate for people who don't use their voices. Welcome, Myra. We have Miriah Nunnaley, the director of Recuperative Care, which is in our Recuperative Care program is a she's in a split operational and nursing role. The program exists to support individuals with an acute medical need who are discharged from hospitals and are too ill or frail to heal on the streets or in the shelter. The program supports optimal health outcomes and prevents costly rehospitalizations. Welcome, Miriah. And finally, Dr. Sarah Stella is an associate professor of medicine, Denver Health Department of Medicine, University of Colorado School of Medicine. She's passionate about advancing health equity through community-partnered, action-oriented research at the intersection of housing and health. So welcome, Dr. Stella. So I'm going to stop screen sharing so that we can all see each other and chat. So I always like to start with the question of, we just did a long data presentation. What did I miss? What do you think we didn't cover? And maybe what surprised you if you're hearing it and you said, oh, I didn't know that statistic. And that question is for anyone. Okay, we got it all covered.
Say something.
Okay, Miriah, thanks.
I think not anything that surprised me, but I do think that the kind of correlation between trauma and homelessness, you mentioned ACEs score. So and thinking about childhoods and how that not only kind of shapes who we are, it kind of shapes what we are, and it shapes our brain literally, because your brain's forming if you think about brain formation through childhood. So I think just keeping in mind the Bruce Perry philosophy of, what happened to you is something that's really important for us all to keep in context when we talk about homelessness and healthcare and access and how to actually kind of get people through systems. And I don't think it can be understated, I guess, is what I would say. We could dedicate multiple education talks to just that, but there's such heavy trauma with the folks we work with that I think that always needs to be at the forefront of what we're kind of thinking about and talking about.
I would just add, Alexis, that we know that our homeless populations across the U.S. are aging, and we're seeing that in all of our settings, especially in particular the hospital where I practice. We know that folks experiencing homelessness who may be only 45 or 50 years old actually have frailty syndromes more like a 70 or 80-year-old person. And we see this not only in the hospital, but with folks living in shelters and on the streets. And so the level of risk for people in this setting of, you mentioned environmental exposures and things like that. So risks to people in the setting of things like malnutrition and coexisting medical conditions is even more dangerous.
I was going to jump on and add one more thing. Sorry, AK. I think stigma affects the people that are unhoused. So the stigma of being unhoused will make a person feel defeated and not want to get health care because they're feeling like no one cares if they do get health care or if they're going to get the proper care. So I think that's another stigma that should be considered when you're thinking about this. Thank you.
Alexis, I thought it was a great summary of obviously a huge challenge that we're all really passionate about. And I think in short, it really touches on the fact of whether you're super passionate about helping these folks with socioeconomic challenges or not, that it is so expensive to allow folks to use an ED as a PCP triage facility. And more importantly, just to really Myra's point, like, why are folks forced to do that out of kind of desperation? Aren't they, fellow human beings that deserve great care and the same kind of equity of healthcare that we all get? So I just appreciate your summary. It's a reminder of the great challenge that is ahead for us.
Yeah, and I'll just add that I think that for us in Housing First in particular, and I know a lot of folks feel similarly, that housing is a form of healthcare. So that's not sort of a relationship there. It's actually an intervention that improves outcomes and symptoms of some of these like medical and mental health conditions that we're talking about. So just kind of a key point there that I think frames our conversation.
Thank you. So one of the things that we talk about is the difference, some of the differences in conditions that affect people, how you treat someone differently when you're working with them. Can anyone who's working directly with clients in that way in a medical setting maybe talk about both how you might think of it differently clinically and also how you might approach someone who's experiencing homelessness differently as a patient and that like sort of trauma informed lens?
I can start. So I practice at Denver Health on the inpatient side. First of all, just to give you a understanding of sort of the scope of the problem at Denver Health, we cared for over 7,000 patients last year who had almost 30,000 visits to our system. And this is a dramatic increase of about 30% from the previous year. So we are definitely, seeing that and feeling that inside of the hospital walls. And then the folks I take care of in the hospital, when we did a survey, we did a point in time survey the year before last and found that about 20% of our inpatients on medicine and surgery services who we surveyed were homeless, and then another 22% were housing insecure. And the top illnesses that we see on the inpatient setting are things like infectious complications, so pneumonias, cellulitis, wounds, infections, as well as just exacerbations of chronic disease. So Alexis, you mentioned that our folks for many reasons are less likely to be able to access primary and preventative health care, which means that they're more likely to seek care for these primary care sensitive conditions. We also, of course, see a lot of folks who are struggling with substance use and behavioral health conditions. And then, my approach when I see someone who is admitted to the hospital, when I go down to the emergency department, is always first to acknowledge what it took for someone to actually come, because it is very, that stigma is very real. And there's a lot of fear that my patients have that maybe meant that they let their wound go uncared for too long. So they come in with more advanced sort of illness and disease. So I call it out. I say, I'm really glad that you're here, that you're getting this checked out. And then we have to recognize that our health systems, although, we're well-intended, people can be re-traumatized through our care. And so trauma-informed care and giving people back some element of control in a situation where they feel like they don't have a lot of control.
For sure. I think that really it comes down to just being people with other people in the same space. And I think that trauma-informed lens, that trauma-informed approach, in my opinion, is about sharing space and meeting a person where they're at emotionally, physically, all those pieces. And then really having the person in front of us guide what happens next from there. I think that's a key part of that experience, and honoring that I don't know necessarily what should happen next, regardless of what I went to school for or what I do for a job. I think the folks that we're working with are the ones that are guiding what we're trying to accomplish from there.
And just to really compliment what Sarah and Jenny are saying, I think, really honoring the fact that people are experts in their own experience. Trauma informed is all about slowing down, listening, giving people a chance to share their narrative, because they are experts, as you all know, in their story, how the context in which led up to having enough guts, like Sarah said, to get into a hospital and ask for help when those systems aren't always easy and frankly friendly to engage with. And I think when we engage people as keepers of their own life story, as people that have something to offer and know about themselves, their bodies, and the treatment they might want to at least collaborate with, I think they respond really positively. I think, Alexis, you said in your presentation, and you're right on that, the idea of what CCH is trying to do differently is to engage every client in a trauma-informed context and in a way that really tries to honor that maybe they're having a tough day today, but that tough day comes from a place of deep historic context.
Thank you. So I mentioned in the data at the beginning that the Stout Street Health Center and its satellite locations are federally qualified health centers. And Denver Health is also a federally qualified health center as well as a hospital system. And so, Sarah, if I could put you on the spot to kind of talk, if someone doesn't know what a federally qualified health center is and why it's unique, could you sort of give a little bit of background on that? And then also, I think how our systems connect and collaborate, and how people who work at CCH and work at UC Health and work at Denver Health connect and collaborate about clients and about the approaches that we have.
Yeah, thanks, Alexis. So Denver Health is, so Stout Street Health Center is a federally qualified health center, which serves specifically persons experiencing homelessness. Denver Health is a vertically integrated healthcare system that serves about a third of Denver residents every year. And our clinics are, we have, I believe we have 10 community health clinics all throughout the city of Denver in various neighborhoods. And the federally qualified health centers are mostly have to do with where the funding comes from. And there's some technicalities to that I won't go into, but I think that we at Denver Health, we recognize that we care for many of the same patients that you all are at the coalition, and that AK sees at UC Health as well. And so we're focused on building and expanding collaborations to better meet the significant unmet needs in our unhoused patients. And so we do that through looking at data and outcomes and trying to understand the risks and the opportunities that we have by working together. And then we do that through programs and systems work to better align our systems so that, for instance, when someone comes into the hospital, how is that become an opportunity for connection rather than a missed opportunity? And so we've done a lot of work with Miriah's team in recuperative care, contracting for recuperative care beds and the new Stout Street Recuperative Care Center. We've also worked with a care transitions team at the coalition to sort of have their team come to the hospital and see clients that are hospitalized there, to really be sort of a bridge back to the outpatient setting, so that you see someone familiar that while you're in the hospital. And then maybe that means you're more likely to want to come to your follow-up visit after the hospitalization.
I think this might be a good point to pivot over to Miriah and maybe talk about the Recuperative Care Center and how that also connects with hospitals and other networks.
Yeah, so I do get to work with Sarah a lot in AK. So we are, we've been running a respite program since CCH started, so for several decades, but We did recently open our new Recuperative Care Center, John Pravinsky Recuperative Care Center. He has earned that part of the name for sure. And it's a 75-bed facility. It's located right behind the Stout Street Health Center, so that close proximity gives us an ability to kind of keep folks engaged. There is permanent supportive housing, a few programs above us. Jenny Deering oversees the CIPRA program. And so it's this integrated building, and our program specifically is meant to provide recuperation after a hospital stay. So it is destined and determined short length of stay. Right now we're seeing folks closer to 2 to 3 weeks. I would like to get that length of stay up a little bit more. But people come to us anywhere from a few days. We have a few people that have been there for a few months that are in chemotherapy, getting radiation. We actually have a gentleman that is going to transfer to another Denver team that is palliative. So he's on hospice appropriate. And we just kind of meet medical needs that wouldn't be able to be met in a street or shelter after a hospital stay. So the shelters can be very packed. There's a lot going on. People's meds get stolen, their ID gets stolen. It's hard to kind of keep your belongings safe. So we just try to provide an environment that's really safe and secure. We have 24/7 staffing. We have nursing 24/7. So people have access to kind of get nursing sort of needs met at any time of the day. And then we have provider care 24/7 as well. We also do integrated health with behavioral health services. So we have behavioral health professionals that are LPCs or LCSWs that work in the program. We also have our new psych provider, I believe Dave is hiring for right now, that'll be providing psychiatric therapy, so and treatment. So it's an integrated care model. So we took all the stuff we do at Stout Street Health Center and then moved it into this building where people will be living with us for a few weeks or months. And the coordination with the hospitals is critical. You know, they need a safe place to discharge people to. We want to keep people from rehospitalizing and going back to see them if we can. And we just kind of partner with them. Sarah in particular is, you know, we meet with her every week. We meet with her and a Denver health team every week to talk about complex clients and talk about how to prevent rehospitalization. We've been able to get some of their clients into some permanent supportive housing. So it's really just bridging this gap of care that will ideally keep people from rehospitalizing the system. Same thing with AK. A lot of our unhoused folks, even in the Denver metro region, do get out to other areas of the surrounding areas. And so we work with UC Health, we work with Centura's hospitals, St. Joseph has beds, Health One has beds. So we literally have partnered with every major hospital system to try to have this conduit that we provide to get folks to us instead of the street that's probably going to result in a rehospitalization.
And correct me if I'm wrong, Miriah, but although we have the partnerships with the hospitals, people can also, as long as you have a medical referral, you can be admitted. And so we have more information on our website, coloradocoalition.org/respite. And we also have a virtual tour of the facility on our YouTube page. So it's, if people are looking for more information or you work in a community program and want to get people in, it is medical, but it doesn't have to be direct from hospitals. That
no, it does require an acute medical need. We do work with other community partners and we prioritize hospitalizations just because that's the kind of most critical need and the one that tends to have the poorest outcomes if they're not supported. But we do have some basically open community beds. There's not many and a lot of people do try to access them. But yes, anyone, we get referrals from shelters or individuals that are going to have a surgery coming up. Or, you know, people that are just chronically ill that can't really figure out what else to do.
Great, thank you. So Myra, as someone who's a CAB board member, maybe not everyone knows what the CAB is, and sort of how do you work to advocate for health and housing for people experiencing homelessness? Or do you have any stories you want to tell about homelessness and health that, you know, aren't covered necessarily when we're talking about data?
Well, I can explain a little bit about the CAB and advocating it. And so as a a previously unhoused person or previously homeless person, I decided to start helping, and I wanted to participate in a group of other people like myself. And that's what the CAB is, people that utilize the services of CCH. And we work together with whatever teams that come through that need help. Like, for example, that we might help with some policies that are being implemented, as well as maybe there's some concerns that are brought about how the health center is being run or something that's not working right, as well as different other aspects, like people bring out people from other organizations in as well, because they need some advice from us as consumers. As for the stories of people getting healthcare, there's been a lot of people that I've known on the streets that had some really serious issues. And by them being able to get into the clinic, I always recommend them come into the clinic, get a case manager, and then they can start getting healthcare, and then they can get housing, because it's like, it's a all-in-one kind of system. Like, the first thing they do is they get the case manager, and case manager can see that they need to get some appointments for their wound care, and then they go from their wound care to where they're realizing that they need more around the clock care or what have you. And so then they go and try to get them into housing. And I've seen a lot of situations like that happen. A lot of people get housed, and then next thing they know, they're going to their doctors all the time. They're getting dental care, they're getting eyeglasses, and now they're like excited because they can cook the right food. So now their diabetes is low. And so I've seen a lot of situations like that happen, especially in my building. I've seen it happen, but I've seen a lot of people in and out the clinic from back in my homeless days that are get housed. They're not on the streets. They're living a good life because they started with CCH. So hopefully that answers your question.
That was an amazing answer. Yeah. And really appreciate you sharing all that. So talking about, I mean, that was a great pivot, talking about the integration of healthcare and housing. And so it's a good opportunity to kind of talk a little bit more to Jenny and to AK, and talk about, you know, how the programs that you work on serve clients. I know we have lots of acronyms and we have lots of complex ways that it works, but it's also relatively simple to explain as well, right? It's like housing and supportive services. So can you talk a little bit about that kind of intersection of housing and healthcare and how those works in your specific programs, and whoever would like to start?
I can jump in. So I think that we also worked with Sarah really closely, and with AK really closely, on a couple different projects. So we kind of all get to work on some of these cool housing pieces in addition to the stuff that's happening at the Recuperative Care Center. I want to talk about the CCH because I feel like we should say that in this setting. It's completely one of the largest projects that we've had lately, where we're collaborating specifically with Denver Health. That's let me back up. The CCH actually means Social Impact Pay for Results Act. It's 100 folks. It's a federally funded program. It is a pay for success model. And the clients in this project are being randomized into a study, and then it's a 7-year project. Once they are randomized into the project, then we work with our community partners, the folks at Denver Health, to connect with the individuals that we're going to be reaching out to and bringing into services. We work with them to connect with housing. And then in some situations, we work with the housing services over at Legacy Lofts and move them into housing there. Although we are doing also scattered site locations for that project as well. But I think, without getting too far into the weeds, what we provide in terms of wraparound services is assertive community treatment. So that is out in the community, really meeting clients where we're at, like I talked about before. We have a team approach where we have clinicians, therapists, psychiatry, nursing peers, really everyone that's kind of in that integrated model, looking to meet the needs of the folks that we're privileged to serve. And yeah, we go from there. So we connect with our folks and work to figure out what we might do from there. The outcomes that we're looking to achieve with that is some of the things we talked about in some of the earlier parts of this presentation, specifically around reducing jail stays, reducing contact with the emergency departments. I think all of those things are really clear outcomes from housing. And that, to me, is some of that integration of housing and healthcare and the positive benefit of housing as an intervention. So yeah, we're working closely with the Urban Institute if folks are looking for more interest and more information on that topic. Urban Institute has tons of information on the SIB project, which is kind of the precursor to the CIPRA. SIB stands for Social Impact Bonds. And that was a project for 5 years in Denver, where we have tons of research about the success of housing and healthcare. So really good reading on that as well.
I would just also quickly add, as a partner on the CIPRA Housing to Health program, so Denver Health is involved as a referral partner into the program. So the healthcare criteria to be eligible for the program are 2 or more visits to the emergency department at Denver Health in the previous year. We are helping to locate folks who may be eligible for the program if they present anywhere in our system of care. That could be the hospital, the emergency department, our Denver Cares detoxification facility, one of our clinics. And then we're doing that through kind of our data systems to help us know when someone's here, and then turning that into an opportunity for connection. So we have a coordinator on site at Denver Health who is going and finding folks and in many cases connecting them in real time with our partners at the Colorado Coalition for the Homeless, who are incredibly nimble and flexible and will drop everything that they're doing to come over to the hospital and try to engage someone around this opportunity. So it's a very nice example of kind of that alignment that we were talking about that's so important, and how the housing and health sectors can partner to really improve health and also improve housing stability. One thing that, just to share a couple of like early learnings from that, we're very early in this, in the implementation phase of the project, but what we're finding is that folks are very medically fragile, many of them. And they also are not folks that are necessarily engaged with other community partners, homeless service providers, the coordinated entry system, although many of them should be engaged. The majority of them, well, all of them are actually meet the definition for chronic homelessness, but it just sort of illustrates that population that we see in the hospital who has so many barriers. And it illustrates why having that alignment and having healthcare be a door for another door for people to enter into the housing system is so important.
Is it okay just to say preach it and just summarize that those 2 answers are just those 2 answers are awesome. I would say, as it's kind of beautifully been said, that and Alexis, as you kind of summarized in the beginning, there's just no question that housing is healthcare, like Jenny said. And I think on UC Health's housing transitions team, which is an outpatient specialty team really dedicated to trying to serve patients that are experiencing housing deprivation or insecurity and really link them to better situations. I'm happy to report that we've been able to get almost up to about 50 patients into some sort of permanent housing, whether that be an apartment or, reunited with family, or even a long-term care facility. And I think, just to summarize some of the wonderful things that have been said already, these folks really, when you give them a chance, give them a dedicated space, more times than not, really surprise you. I think Myra's summary of just one engagement at South Street Health Center and how that can change someone's life if you just make space for them. But I have to say, I'm really lucky. I work with 2 really talented social workers, Avery Perry and Alex Washburn, and just an amazing nurse, Brooklyn Booker. And so they're the ones out there really doing the hard work of trying to really improve care once a patient discharges from a UC Health, typically Anschutz, and then connects to either shelter. And then we begin the work of trying to patch together some respite kind of extension stays, or utilize one of our beds at South Street Recuperative Care Center, which I just want to say, Miriah is really humble, but it is truly a world-class facility. I think it's going to really show not just the United States, but the world, what happens when you dedicate, such a world-class facility to patients that deserve it. So it's just inspiring to walk by that thing and see it. But in summary, I just want to say that I think what we've shown with the coalition, we had a partnership called PartPad, which linked 10 patients from UC Health experiencing homelessness into protective action, which happened during the depths of the pandemic, into permanent housing. And Jenny's team and her talented caseworkers surrounded those patients and linked them to permanent housing. We were a bridge that I hope created some meaning for CCH in terms of really trying to prep patients before they got into a motel, and then help them through the process to link with CCH and the Salvation Army. And we currently have a partnership with the Denver Housing Authority, and they have generously, to their credit, given us 22 housing vouchers. And my teammates really are working hard to try to link those folks to some permanent housing opportunities. We also hope to maybe do some of that through CCH, and we've also partnered with Housing Connector. So just lots going on, but really so thankful to be part of maybe hopefully a stronger continuum from hospital to permanent housing.
Yeah, I think I'll add to what AK is saying. With the COVID pandemic was obviously a really a big learning experience for everyone. And I think it really highlights the importance of housing in relation to healthcare, right? When you think about the guidance around COVID and that we were all supposed to stay home and stay away from each other, but there's a key part of that of home. And I think a lot of folks who were unhoused during that time really were struggling to figure out, how do we navigate this new thing that we're doing? And so, yeah, I think that was a huge success, the partnership that AK mentioned of leveraging the protective action and then creating lasting solutions, as we say in our mission statement, long-term solutions for homeless recovery from that protective action sites. So it was a pretty cool experience to see that happen.
Thanks. And thank you, Miriah, for putting in the chat a link for the SIB report. So we're saying SIB and CIPRA. The interesting thing about the SIB program is that it's very similar to CIPRA that Jenny explained, except the analysis part that the Urban Institute was doing has concluded. And so the report exists, and it essentially found that people who had housing and supportive services had reductions in shelter stays, police interactions, jail time, emergency detox services. They used less emergency health care, received more office-based care, and had better access to prescription medications and overall better access to preventative care. So that is an independent study that was done by the Urban Institute, and that is how we're so excited to be doing the CIPRA program, which builds on that and has more of a health emphasis even than SIB did. So if you like reading reports, it's in the chat.
And I'll also add that part of the criteria for SIB didn't include a piece about healthcare or medical need. And I think that was really instructive when we were thinking about the CIPRA. So that was a real key part that we realized the medical need that was involved in the population we were serving with SIB. And that really helped us to formulate sort of the groundwork for the CIPRA. So they're kind of separate, but also connected in terms of the thought process there.
Thanks. So before we get to questions in the Q&A, and I think there might be a couple in the chat, I'd like to end on a question. I'm giving two options for how to answer this question. It is for everyone. So you can either answer the if you had a magic wand, what would you change in the healthcare or housing system? But if you're a little bit more down to earth, on the ground, more like if you could implement some legislation, something that really can happen, that you think that you want legislators to know, that you want people who are making decisions, you want anyone who's out there to, you think that would be a good policy change or substantive change that we can make. So either one that you would like to answer, and whoever would like to go first.
I'm gonna go first. If I had a magic wand, I would have a whole team per person, especially the people that have been chronically homeless or unhoused. I would make sure they have a case manager, they would have their behavioral health person, they would have their housing person, of course, their primary care, their doctor, well, the doctor is the primary care, but their dentist, their eyeglass, even somebody to help cook them the right meals if they had diabetes. So that way it wasn't a struggle to break down that stigma for every single person you have to interact with. So.
Go next. So we all know the root cause of homelessness and it's a lack of affordable and available housing. And we know that Denver is the 8th least affordable city in the United States. And so I would like for us to scale housing and make major investments in housing, and not just housing that like people are talking about out there, but like the right kind of housing for my patients. So that is supportive housing with wraparound services, which is the model that Denver has proven is effective, as well as many other previous studies have proven it effective. So that'd be my first thing that I would do if I had a magic wand. And then beyond that, I would love for us to scale some of these solutions to take what we're learning through these collaborations and really have a community approach to improving health among people experiencing homelessness. And so we would really have our systems would be aligned and working together. And so it goes back to that hospitalization being an opportunity for connection rather than a missed opportunity.
I think it's an awesome point. I think in the end, I would summarize by saying that we need to operationalize that housing is a human right, and that it isn't a privilege or something that needs to be earned, but that fellow human beings deserve kindness and grace and an opportunity, as Dr. Stella said beautifully, to whatever entry point they get into, whether it's a hospital or a shelter. We need to scale up and keep the government accountable about what we do to create a strong, clear, and logical continuum pathway that helps people go from Denver Health, UC Health, and other hospitals or shelters to permanent housing, and then adds, Myra's great suggestion of a team that really is dedicated to them. I think people love to talk about the expensive things, but I think as Miriah and others, and Alexis, you too, have done a beautiful job of talking about how expensive it is to be indifferent. And so I would just say, my wish is to both legislate and create a magic wand at the same time.
I think I'll just add that all the things that AK and Dr. Stella said and Myra said, all of those things. Also, I think that behavioral health is healthcare. So I would increase access to behavioral health care. I mean, access, more doors, more pathways to services and housing, but particularly as a clinician myself, I think behavioral health care, more of that, more access for everyone.
I would have a wand that copied everyone else's wands. I think Sarah's right. That report that recently just came out, right? Denver is now the 8th least affordable city in the nation, and we are compact and we don't have access to much housing. I actually would probably wave my wand differently, though. I would wave it where all humans had to probably have a little bit more forced empathy, because I think when I think about the discussion around homelessness, there's a lot of misinformation and a lot of assumption and a lot of context missing. So I read statements and I think to myself, well, there's data that shows that differently. So thinking about, when you talk about people not being compliant, a lot of times it's because they don't have access. And, a lot of times we add this moral element to poverty. So when I talk to people about substance use and I think about a wealthier neighborhood I used to live in Central Park, and people would walk around with glasses of wine, that was never talked about or judged. Whereas, if people in poor neighborhoods walk around with malt liquor, it's seen very differently. And the reality is it operates in our body the same ways. And so I think I would wave our wand so all of us were able to zoom out a little bit with some of the beliefs or assumptions we have about homelessness and really pick them apart and look at the data and the reality and the why of why people are, and look at things from more of a resource and access lens than a judgment lens.
Great answers, everyone. Thank you so much. I'm gonna move to the questions that we have in our Q&A function. And so the first one, I will preface by saying it is about substance use disorders. And I do want to mention that we are going to have a dedicated session about that next month. So that doesn't mean we shouldn't answer it now. It just means that we'll be able to get into more detail next month. So please be sure to register for the July 20th session. So this is the question. I work alongside the downtown Denver homeless population with a group that cleans up after them. Field experience is showing us that drugs seem to be one of the largest factors towards pushing individuals to the streets. That drugs are also a major motivator for hospital visits. Curious how we can support these individuals with any of these programs when drug use has not been mentioned up to this time.
I think that that's something that, in my mind, I think behavioral health includes mental health and substance use treatments. So I think I'm probably using terminology from like maybe a slightly more inclusive sort of thinking, like both and at the same time. In my mind, I'm a licensed addiction counselor and an LCSW. So I think of those things as concurrent, that when we're providing intervention and support to our clients, we're looking at the whole person involving those things and then tailoring what we're doing to what particular thing a person's looking to work on really in that moment. So I agree with you. That's a big part of the work that we do. And I apologize for not saying that like more specifically broken out versus just behavioral health in general.
Yeah, I mean, so go ahead, sorry.
I was just going to add on to what Jenny says. I agree, because a lot of times the substance misuse is a side effect of the behavioral health, and a lot of people see it as a contributing factor when really it's a side effect from the lifestyle that they're living. And so just having those opportunities to either with harm reduction or give them a chance to try to recover would be the most helpful. Anything you can do to help towards that would be helpful. I mean, I believe that the whole world went through some kind of substance misuse at one point in time, even if it wasn't permanent. It was something to help them deal with their issues. So it's something to think about. Thank you.
And we also just don't have great, like there's this chicken and egg dilemma, right, of substance use and behavioral health issues. And a lot of people do turn to substances to manage chronic pain or PTSD or depression or anxiety. And so I think, again, thinking about things from an access lens, are they managing something with substances because that access isn't there for another approach? It's certainly part of the equation, like Jenny said, and it is a reality of the work we do. But I think there's enough data that it's not causal, right? Like it's not that we can draw this line directly from substance use and if you use substances, you become homeless. That's not it at all. There's a lot of layers, and I think thinking about it in terms of access and what are people treating and how are they treating it has to be something we have to think about with harm reduction and things that we do know work with substance use discussions.
Thank you.
I'd quickly add that, I think it's not, we also know that Denver or Colorado is, I think actually the worst state in the nation when we look at access to mental health and substance use treatment. And so we really need to, that makes it very difficult for people to actually access the supports that they need. And then I think that also we have to have, everyone's different, and we really do have to have sort of an individual lens on this. It's not a one size fits all approach. And I think that we need different strategies for different patients. I think sometimes the people that are out there doing street outreach, that are case managers that really know our clients and patients best can be really helpful to engage in those conversations about what's going to work for someone. But there's a lot of innovation going on around the country, including Colorado, on care models to deliver better treatment and improve access. But we really need a lot of we need a lot more access to what we know works.
Thank you. We have a question from Parker. It says, have behavioral health therapeutic opportunities such as mindfulness education or CBT been integrated at any point in your care spectrum? This may be fascinating for the Urban Institute to review.
For sure. I think CBT is a great intervention. I particularly like acceptance and commitment therapy, which is a form of CBT.
Sorry, will you I apologize, I should have said, will you say what CBT is?
Oh,
Also?
cognitive behavioral therapy. Apologies, we're throwing acronyms left and right here, and I just get a little excited when I talk about therapy things. So yeah, I'm particularly a fan of acceptance and commitment therapy, to throw another ACT acronym at everyone, which is a form of CBT, but I think has some mindfulness components and some really cool, it's a pretty cool intervention for some of the folks that we might work with. But also CBT is great, also very historically used for substance use treatment. So kind of on topic for what we're talking about.
Okay, we have a question from James. Says, and I know, Miriah, this is a passion of yours. It says, I always want to point out that end-of-life care is healthcare, and people experiencing homelessness deserve care as much as any other. I don't know that I have a question, except perhaps, why isn't this fully funded around the nation? So Miriah, do you want to talk about end-of-life
Yes.
care? Because
yeah, JP is wonderful. I'm on the board of Rocky Mountain End of Life Refuge. I think of anything I think I can get most people to agree on, it's that no one should die not in a bed comfortable. I think it's really hard to find someone that disagrees with that. So it is fascinating to me that end of life care is complicated in this country. It's a very complicated part of our healthcare continuum. And it's just hard to provide it in most of the places that unhoused individuals can access. And so, people end up getting it in the hospital or shelter sometimes, or, the shelter in the refuge, where the point is that. But I think JP, probably when I read that comment, I'm thinking that the reality is one of the challenges we all have is we are working in a very complex, complicated for-profit healthcare system. And so Sarah has to discharge people if they meet criteria for discharge, whether she wants to or not, same with AK and the providers at UC Health, right? And I have my own criteria I have to kind of honor for my program. And so I think one of the challenges with this coordination we're working on and thinking about healthcare being housing is that if we were to all kind of change course and demand a city or a state or a country that did think of healthcare as housing, it would fix a lot of these issues, or at least support these challenges that we all have and are concerned about. Because the barriers oftentimes are the systems we're working in. And, end of life care is one example. Sarah mentioned behavioral health care access period in Colorado is another example. So I think just the reality of the systems we're working within and against and trying to change are also a big challenge to what we're all trying to do.
That's a great point, Miriah. And I think that, we strive to look at every patient, really meet that individual need. And that's a big driver. We literally do not have the resources and the post-acute care options for our patients. So the Recuperative Care Center is a great start, but the demand for that in our community far outstrips what is available. So we need people, we need a variety of different options and partnerships. And, our patients are the biggest motivating source for that. We really, strive to look at everyone's individual need. We try to think outside the box to get people into the right level of care, whether that's end of life care or something else. But, sometimes that literally does not exist. And so I think it's on us to collectively advocate for what our patients really need.
Thank you. There's a question from Sharon. How can organizations like CCH help library workers who often feel like they are frontline specialists but aren't really trained as social workers or case managers? I was a Vista with CCH in the late 80s and am now with Jeffco Libraries for almost 2 years. So many people who need help come to us for daily shelter and safety, but it's difficult to get resources to individuals who can come and go at will. I know everyone on this isn't exactly our outreach teams, but if you have suggestions, please add them. And I will let Sharon know also that we haven't announced it yet, but we do have a plan for our October session to be for sort of those gap fillers, people who aren't trained in this work, who do this work, like librarians and teachers. So we will plan on addressing this. And Sharon, if you or anyone else has ideas of what we should cover in that, please let us know. We really build these things as we go. So please help contribute if you have ideas. But that being said, if anyone here has answers for Sharon, please add.
I was just gonna say, Alexa, since you guys already have a good series on trauma-informed and different types of things that the librarians and teachers already interact with, even though you're providing the information to the community, I'm thinking you guys have a lot of stuff that they can learn from. As when I was trained as a peer specialist, and I know some of the libraries have peer specialists that have some of that trauma-informed care kind of training, that I'm sure some of the classes that or the presentations and workshops like you're presenting now, they can learn from that first as we're waiting for these kind of things, so where we can combine and work together as collaborative so we can all care for the same population. So I just thought that was
I think us all to think about, like, we need to vote, people into our local offices and representation in state offices that help us get more resources. I think I look at this question and I say, there's a lot of resources I think I can see that you need that you're not going to be able to access currently. And I think, we have to think about what kind of community do we want to live in, and how do we want to make that happen, and making sure that there are community engagement and outreach teams, and that the STAR team has more funding, because they're at capacity, and thinking about how healthcare systems have to bill and operate, and they get funding so that they have funding, how nonprofits get funding. All of resources cost money and access costs money. And so I think we all have to figure out how to ask for what our community needs, and then hold our representation accountable to that, because sweeping people and not seeing them does not fix, any of these issues. And I love DPL. I love my little DPL sweatshirt. I think it's one of the coolest resources we have in the community. And those first line workers there are working as social workers, and they are working as care coordinators. And, so we have to build community resources so people have access to learning about resources and access to training and mental health first aid and things like that. So I think it's all about figuring out, what our community needs. And when I say community, I mean Denver Metro, including I live in Aurora, like this area, Denver and surrounding areas. How do we get those resources out, and how do we get them where they're needed, and how do we hold the people accountable that should be responsible for ensuring that happens?
I think one thing that I've been thinking a lot lately, especially as someone that lives in Denver County, is unlike never in my lifetime, I've seen homelessness become a major topic during the mayoral race here in the city. And we will have a new mayor. And I think I mean this with respect and care, but we need to hold the new mayor to account and work with him and his administration to really see what we all, just to kind of complement what Miriah is saying, can do together to address some of the proposals that he recommended. And I think I really think it's a wonderful point about are we going to participate? Are we going to advocate? And are we going to engage the people that we elected and do our part? I think I'm trying to become more accountable in that sphere too. And I think it's certainly not something that we just give to the mayor or someone else. I think it's something that we all do together. But I think Miriah is exactly right.
Thank you. Well, I apologize. I know we have a couple more in the Q&A, but we are coming up on time and I want to be respectful of everyone's time. So I'm going to wrap it up, but please feel free to follow up via email with additional questions and come to future sessions and check out our website. We can get you connected. Just going to quickly share, as I mentioned, our July session is going to be about substance use disorders and homelessness. For August, we have planned to talk about older adults and homelessness. Some of the things that came up today when we're talking about health are going to be dug into a little more because we knew this was pretty broad and we couldn't quite cover everything. So please join us in the future. As I said, they're all on YouTube after the fact. But we really do put these together as a team and we consult with different folks. And so if you have ideas for sessions, if you have feedback on how tonight's session went, you'll get an email tomorrow and it'll have links and you should be able to provide feedback. This is a community event and we want community to participate in every way before, during, and after. So please, engage with us. And that's all. Thank you for joining us. I want to thank our amazing panelists. I think that was one of the best. You guys were amazing. And thank you to everyone who once again decided to use their evening to learn a bit more on this topic. Please do share it with others if you found it useful. And I will also mention that we are updating our health and homelessness report. So we put one out in 2019. Our team puts together some really amazing reports with a lot of data. If that data presentation wasn't enough for you, we're going to have an updated 2023 version of the report coming out by early next week. So be on the lookout for that. We may be able to put an email to you. It may just be on our social media, but find it, learn more, and we can dig more into some of those details. So thank you again. Have a great evening.